Good afternoon to you, ladies and gentlemen. This is O.P. Yadava, Editor-in-Chief of Indian Journal of Thoracic and Cardiovascular Surgery and CEO of National Heart Institute in Delhi. It's indeed our proud privilege to play host to Professor Martin Elliott. Martin, welcome.
Thank you very much.
Professor Elliott is Professor of Cardiothoracic Surgery at the Grange Ormond Street Hospital in London, and we're going to exchange some ideas about the modern healthcare as applicable to maybe the entire field of medicine, but more specifically for congenital heart diseases. Martin, what is the current state in UK as far as funding is concerned for these congenital heart diseases and cardiac surgery in general?
Well, funding is challenged in the UK because of some strategic decisions governments have made since the financial crash.
Yeah.
They introduced a policy of austerity, which meant that the health service budget was reasonably protected, but didn't increase with the rising population and the rising birth rate. Together with other social changes like an aging population, more dementia, and more people needing care, we've ended up with a situation where there is functionally less money for everything else. And so for a high-intensity specialty like congenital heart disease, there are problems around capacity, around staffing, around where stuff is done, and the scale of the whole organization, and how those relate to the community in terms of follow-up.
That's what my next question would have been. That has Brexit has anything to do with our capacity in terms of the human resources, the nurses, the paramedical staff, and the doctors?
Well, the capacity question needs to start by defining where it is, where the capacity constraint is, and it's largely in the intensive care unit.
Okay.
So the number of pediatric intensive care beds in the UK is probably too low to have any margin. Most of us would like to run an ICU with an 80% bed occupancy, but we're running close to 100 all the time. So a lot of last-minute consolations throughout the country. That capacity constraint is added to by the fact that Brexit has had a big impact on the number of nurses from the EU applying for work, a 95% reduction in the last 12 months, reduction in nurse applications. And our Home Office, because of the whole sort of paranoia about Brexit and immigration, has also had an impact on people wanting to come to our country from other places. The Home Office make it difficult because we've got a bunch of right-wing people in our country who suddenly feel nervous about immigration, despite the fact that most of us who live in the UK don't give a toss about it and thoroughly enjoy working with people from everywhere else.
So what's the government doing, or what's the association doing for capacity building, opening new colleges or training centers? Or
no,
what?
On the contrary, we spent quite a lot of time trying to rationalize the number of centers we've got in a program which has been being developed for almost 15 years now, to reduce the number of centers, and they're down to around 11 from 15 as they were. So we have had some reductions. So the centers are bigger. The more you do, the better you get principle. But that doesn't leave us much margin if we're trying to do anything. And it's unlikely, I think, that in the foreseeable future, there'll be a great deal of increase in investment in our specialty. I think the burden, therefore, falls on us to learn from you in India, and particularly from people like Devi Shetty, that if you're running a business, you can sell more stuff or you can make it cheaper. And I think that we need to start concentrating on looking at new ways of working and reducing the cost of what we do. We should not be in the 21st century as labor dependent as we are as the technology proceeds. And we have to look at the way in which we can apply different ways of nursing, the use of artificial intelligence in intensive care units particularly, and different modes of follow-up. And why do we see people in outpatients, for example, when we might one day in the near future be able to attach sensors to them, which will mean that we can feed their data into an algorithm and only see them when we need to. So I think these models need to be tested and thought about, because the number of staff is unlikely to go up and the workload is likely to rise. And knowing governments as I do, they're unlikely to chuck money at us. Our mortality is low, and the problem in their scheme of things compared, say, with dementia is not worth solving. Our mortality is close to zero. So why would you throw any money at it if you're a Secretary of State for Health?
I appreciate, I mean, there are concerns about, you know, there was a time 10 years back or 15 years back when they were talking of outsourcing the work. And lots of people were allowed to travel outside Britain to go out for Eastern European countries for the surgical intervention, which were not covered in Britain. Is that being considered now to source these patients to countries like India, which may have adequate infrastructure, the language is not a barrier, we speak English, or that consideration will not be accepted?
I don't think it would be an official offer, but unofficially people do it. So maybe not for cardiac surgery, but they do, for example, for plastic surgery, for dental work, come to a variety of other countries. I'm not sure that because long-term follow-up and risk of mortality and complexity probably militate against that being useful in our own country. But France is up for making an offer because they've got spare ICU capacity. So there have been a few phone calls saying, well,
what are the current wait lists? I mean, NHS has been notorious for wait lists. So with this sudden exodus of your manpower, is the wait list gone up?
Well, I don't think it's so much of an exodus as a not applying.
Yeah.
So that's the first thing. No, I think the waiting list is actually under control, but we're running faster in order to maintain that work. Our staff having increased emotional load of having to deal with last-minute cancellations, and they keep pace with it. But it's, you know, when you do work and your work feels like hard work, it's less satisfying than you're just doing good work.
Any thoughts? We in this part of the world, and it's been done all over, and everyone is talking of cost containment, but there's no reuse policy in Europe. No, why is that?
Well, I think it's, well, first of all, a rational, original obsession with safety. Second one is, I think that the big...
But it's been proven that that's very safe.
So, but I think big pharma and manufacturers control the market, essentially. I think globalization has tended to work in one direction. We should be learning from you about how these can be safely reused. Those papers, that information has not been widely shared or published in the United Kingdom, which I think is quite wrong. And I feel very strongly that we should be reusing stuff. I don't know, I haven't personally started a campaign to do that, but somebody should. It's quite wrong that these companies are constraining the way things are done.
So, ladies and gentlemen, we just heard a very astute mind in the field of organization and administration, Dr. Martin Elliott, and he bats for that there should be collaboration across the world of learning ideas, and some of these policies regarding reuse and recycling should be revisited. There is need for capacity building and improved infrastructure, not improved in terms of maybe quality, but at least in terms of quantity for the Western world too. Thanks, Professor.
Thank you very much.
Thanks for sharing your time with us.
Thank you.
Right.